Hi, I'm Dr. Selina McGee, and I practice in Edmond, Oklahoma, in a primary care practice. So we do primary care, of course, and then specialty contact lenses along with ocular surface disease. I do a lot of aesthetics as well. Here we're going to talk today about our experience with our patients that are moving forward with cataract surgery, or even a patient that has chosen to do a refractive lens exchange. So I'm joined by my good friend, Dr. Carolyn Majcher. Tell us a little bit about yourself.
Such a pleasure to be here. Thank you. Dr. Carolyn Majcher. I'm an associate professor and the director of residency programs at the Oklahoma College of Optometry. And I see patients at the college, but also through the Cherokee Nation Hospital system there. And my particular areas of focus are retinal disease.
Perfect. Okay, so we have to talk about something before we jump in, because this is how passionate she is about the retina and all of the things. So tell us, in this super cute black and white dress, what is actually on here?
OCT angiography of proliferative diabetic retinopathy, yes.
There we go. I'm so excited. So it's so cool to be here with you. You're
Me
such
too.
an expert. So let's dive in. Let's talk about our patients and what we should be doing to diagnose and manage patients that we're looking for with retinal disease. So I'll just give you kind of my clinic, what we do for our patients, and then I would love for you to walk us through what that means or what happens when we see something that is new and different. So in our clinic, we actually do an OCT, we do wide field photography on every single patient along with mammography. So walk us through, a typical day in your clinic, and what are the things that we should be doing for our patients to make sure that their retina health is what it should be.
Yeah, I think very similar to what you're doing. We incorporate a lot of wide field and ultra wide field color fundus photography in order to pick up really subtle, even diabetic retinopathy lesions. Also, we have fundus autofluorescence wide field and ultra wide field, which can be really valuable for more subtle pachychoroid diseases such as central serous chororetinopathy. And OCT, of course, is critical. So macular OCT is probably the best way to screen for subtle macular disease prior to referring for cataract surgery. But don't forget about the optic nerve as well, because optic nerve diseases also impact contrast sensitivity as well as color vision, and that's something that you should screen for prior to referral.
Right, because if we're going to talk about, let's say a patient is choosing to do a premium lens and they're looking for the least spectacle dependence, if they have an underlying issue where they already have a problem with contrast and we choose a lens that's a multifocal that is now splitting light, that patient's probably not going to be happy.
I couldn't agree more with you. In a patient that has macular disease or optic nerve disease, they already probably have some sort of degree of contrast sensitivity impairment, color vision impairment, or perhaps even some visual acuity impairment, in addition to the cataract changes that maybe it's hard to assess and pick up on prior to referral. So that would not be a good scenario in terms of putting in a light splitting premium IOL, because it would further decrease contrast sensitivity for that patient and make probably even daily activities of daily living more difficult for them, especially reading or low level light situations.
So walk us through, because I don't routinely check color vision or contrast sensitivity on patients. Walk us through actually how to do that.
I very much focus on the retinal imaging to guide me in terms of whether they have macular disease or optic nerve head disease. But certainly there are commercially available and very easy to use in the clinic contrast sensitivity charts, as well as the HRR is like my go-to for color vision testing. But even something as simple as like a red cap test comparison between the two eyes can tell you a lot about optic nerve disease, such as glaucoma, past episodes of optic neuritis, etc.
Perfect. Okay. So let's talk about a patient that has diabetes and is ready for cataract surgery. How do I know that that's okay for the patient to move forward with cataract surgery? What special testing should I be doing? Do I need the retina specialist involved before they have cataract surgery? Walk us through what that looks like for that patient with diabetes, with and without evidence that something is different happening in the retina?
That's such an excellent question. And I think it depends on the stage of diabetic retinopathy. So if a patient has like mild to like mild moderate non-proliferative diabetic retinopathy, I see no issue proceeding forward with cataract surgery. Of course, assuming there's no macular edema present, which can occur at any stage of diabetic retinopathy. So by doing a macular OCT scan, you can easily screen and rule out macular edema prior to making that referral. Once you have a patient that's like severe non-proliferative or is proliferative, maybe already had PRP or is undergoing anti-VEGF injections, it's something that you probably would want to get a retinal clearance on, as well as, again, screening for macular edema to make sure that that's not something that could progress during the surgery.
Sure. So here's a question. When we look at patients, so if they go through cataract surgery, are there specific things afterwards that we should be focusing on? Are they at higher risk for cystoid macular edema?
Certainly.
Okay.
Yes.
Okay.
And that's something you should definitely be screening for post-surgery.
Post-surgical. Let's talk about the patient that does have an epiretinal membrane that we catch ahead of time.
Mm-hmm.
What kind of education would you give to the patient on what to expect after a cataract surgery in the presence of an epiretinal membrane that doesn't need a surgical procedure for that? Walk us through, how do you talk to your patients about that and what to expect?
Yeah, so setting realistic expectations is so important in having a good patient outcome and patient satisfaction, right? So letting them know that they're not going to have a very crisp, like perfect vision after the surgery is really important. There may still be some residual distortion or metamorphopsia that the cataract surgery is not intended to correct.
Yes, and that's so important because when we talk to patients ahead of time and they understand what to expect, because they realize, and sometimes they don't, even when we do our best job talking to them, they think the cataract surgery is going to fix everything.
Yes.
And so, making sure we keep those realistic expectations of, like you described, we may still have the little wave in your vision. It may not be the 20/20 perfect, because the way I explain it to patients is the film in the back of your eye is a little bit different. We're just replacing the lens. And so I can't fix the film. I can fix this part. And we can certainly make things brighter. And when you have better contrast, that helps patients not with the way that they see. So I think sometimes too, we get caught up in a patient being 20/20. That's just one measurement with how a patient sees, but that's not really their whole visual system. And so anything we can do to help with contrast. So do you have tips for us on patients that struggle with, a 20 unhappy patient afterwards? What are some things that we can do to help them get to their best vision possible?
Sure. I think trying to be in a bright illumination setting, especially for more demanding visual tasks like reading small print, is going to be helpful, and having the light actually directed on the print would be important.
The right light matters, like the way that they use it.
Absolutely, that's a great point as well. And then, letting them know you may have to throw on some readers, just for that little extra boost when you're reading. We may not be able to gain full independence from glasses.
I love the words that you use, and words really matter the way that we describe this. If we set the expectation that you're never going to have to pick up reading glasses, that's really unrealistic. So I like what you said, the less spectacle dependence and knowing what the patient expects so that we can best meet those. So let's talk a little bit about just how we communicate with the surgeon. So if you have a patient that has an issue in the retina, what do you let the surgeon know as that conversation? Do you send chart notes? Do you say, look, best limited BCA is going to be this afterwards because of this issue? How do you communicate with the surgeon?
Yeah, I typically don't myself perform like PAM, like potential acuity meter or anything like that typically, but at least give them a heads up that there is some sort of retinal or macular disease or optic nerve disease for them to be aware, so they know to avoid in putting in like a premium or light splitting IOL individual like that.
And it's nice because we have expanded lenses now. Historically, we've only had lenses that split light, but now we have extended depth of focus. We have light adjustable lenses that we can still choose that don't split light, that can give a patient a different visual outcome than what we've traditionally had. So the technology is certainly helping us in that space.
And I would think, a light adjustable IOL would still be very appropriate because it's still like a monofocal type of lens that isn't going to cause a lot of hit or effects with contrast sensitivity or color vision or anything like that. Probably an accommodating IOL would also be an ideal scenario over, say, like a trifocal type of IOL.
Right. So walk us through, because macular degeneration is certainly more prevalent than I've ever seen and happening at younger ages, unfortunately. So if a patient has small drusen, how do you approach that patient during cataract surgery? Walk us through that scenario. We've talked about diabetes, we've talked about glaucoma. Walk us through a patient with macular degeneration.
I think it's really important to rule out that there's any neovascularization or exudation present before you send a patient with macular degeneration for cataract surgery. And OCT does a very great job of letting you see exudative features such as fluid on structural OCT, or if you have OCT angiography, you can pick up even really subtle early neovascular membranes before they leak out fluid. And you'd want to exercise more caution in that situation and monitor them more closely postoperatively. And we've been talking about diabetic retinopathy and macular degeneration. I think it's important to remember that these are progressive diseases. So just if you're catching them in the mild NPDR stage, if their hemoglobin A1C is, say, like 12% or something, in a few years they could be severe non-proliferative and have a lot of functional vision issues as a result of just the retina component.
Right. And that would definitely drive what we're choosing to marry that technology with for that patient.
Yes.
And being cognizant of that, I think, is really important. We touched a little bit about fundus autofluorescence. How do you use that, and what does that tell you different than your traditional photography?
Well, you bet. So fundus autofluorescence tells you about the amount of lipofuscin in the RPE. So it's telling you about the RPE and photoreceptor metabolism, essentially. And I can tell you a lot about outer retinal diseases. So macular degeneration, it's a great way to image geographic atrophy, reticular pseudodrusen, even really subtle changes in the retina that occur in pachychoroid disease. Pattern dystrophies is striking what shows up on fundus autofluorescence.
Very good. We're fortunate enough that we get to do both in our clinic. And so, being able to utilize those tools to the best of our ability to take great care of patients has certainly been such an addition to our clinic. Let's talk about, just for a moment, you mentioned geographic atrophy. Tell us why that's important now for ODs to really understand what they're looking at, what they should be measuring, and why that's important for
Certainly. So there was recently approved a complement inhibitor for the treatment and intravitreal injection for the treatment of geographic atrophy, basically to slow the growth. But again, we can't halt it. It's still going to progress, like many retinal diseases do, unfortunately. But I think it's important to screen for that, especially because the VA doesn't match always in geographic atrophy. So you could have extrafoveal geographic atrophy with 20/20 vision, but it's going to continue to expand, and by the time it hits the fovea, that patient's going to have a reduction in vision that's rather sudden, and they're going to have a lot of issues, especially if they have, say, a light-splitting IOL in place.
Very good. There's just a wealth of knowledge. I could talk all day. So let's just recap, and definitely leaning into our technology to help us really care for the patient, making sure that we address issues like subtle changes in the macula, whether it's diabetic macular edema, macular degeneration, geographic atrophy, that patient still has perfect 20/20 vision. Those are all really important things that we should be looking at ahead of surgery so that the patient has the best possible outcome and has the expectation they so desire after cataract surgery. Thank you so much for being with me today.
My pleasure.
Absolutely.
Thank you for having me.